Thank you, Luke, for your inspirational dedication to Bob. I can't think of a more meaningful way to kick off today's inaugural Patient Forum. Hi, everyone. My name is Joanne Gold, and I'm the Executive Director here at the Scleroderma Research Foundation. I'm thrilled to see so many of you joining us today. We're truly honored that you've chosen to be here. We're also very proud to be able to partner with some of the most distinguished leaders from the scleroderma medical and scientific community in bringing you their latest research updates and sharing some of the important ways in which patients can be a part of helping to drive discoveries forward. Because as Luke just mentioned in his remarks, we can't end this disease without the collaboration of the entire scleroderma community. Finding a cure for scleroderma is and always has been our singular focus. It's why the SRF devotes a greater percentage of our annual budget to scleroderma research than any other nonprofit in the US, and what makes us the largest nonprofit investor in scleroderma research in the country. All of which is made possible through the generosity and unwavering support of you, our scleroderma community. Thank you. And now, before we begin the forum presentations, I have just a few details that will help you navigate the day. Today, we'll be offering a total of 7 sessions. Each session is approximately 30 minutes long and includes a 5 to 10 minute live Q&A. The sessions will run back to back and start automatically, so you won't need to end one to join the next. You can submit questions for the Q&A at any time during the presentation by typing it into the panel on the left side of your screen. Our guest moderators will select a few questions to be answered live by each presenter, and any questions that we don't have time for will be answered via direct message or a follow-up email. Lastly, please note that there will be a 20-minute intermission during today's forum at about the halfway point following the genomics session. But just before the intermission, we'll be sharing a video clip of our dear friend and board member Bob Saget from last year's virtual Cool Comedy Hot Cuisine, which I know many of you will want to watch. Okay, now it's my pleasure to introduce the first session, What You Need to Know About Systemic Sclerosis and Research, hosted by Dr. Lorinda Chung. Dr. Chung is a professor of medicine specializing in immunology and rheumatology, as well as a professor of dermatology at the Stanford University School of Medicine. She is the director of Stanford's Scleroderma Program and co-director of its multidisciplinary rheumatologic dermatology clinic with Dr. David Fiorentino. Currently, Dr. Chung is involved in clinical, translational, and epidemiologic research on systemic sclerosis and related connective tissue diseases. She is also a principal investigator from multiple clinical trials of potential new therapies for scleroderma patients. Among her many research interests, Dr. Chung is studying the genetics of severe calcinosis and scleroderma. So, without further ado, please welcome Dr. Lorinda Chung.
Good morning, everybody. Thank you so much, Joanne, for that very nice introduction. And thank you to the Scleroderma Research Foundation for inviting me to give this introductory talk at the inaugural Patient Forum. This is really exciting that the SRF is now supporting a patient forum, and I'm delighted to be able to speak to you today. So I'm going to be talking about what you need to know about systemic sclerosis and research. So I just want to give you an overview of what I'm going to be talking about today. First, I'm going to touch upon the pathogenesis of systemic sclerosis, or what causes the disease. Then I'm going to give an overview of the clinical features of systemic sclerosis, or what the disease looks like. Then I'll talk about the different types of research that are being conducted in systemic sclerosis, and touch upon the research challenges that we as investigators deal with in terms of research in scleroderma. And finally, end on future steps in systemic sclerosis research. So first of all, regarding the pathogenesis of systemic sclerosis, patients ask me this all the time: what is causing this disease? So we believe that there is a genetic predisposition. So the genes definitely make a difference in your risk for developing systemic sclerosis and for autoimmune diseases in general. And we know this based on the fact that families often have clustering of autoimmune diseases, including scleroderma. In addition, there have been discovered some common gene abnormalities in various autoimmune diseases, again, including systemic sclerosis. But genetic predisposition isn't enough to give you the disease. So we know that there has to be some trigger that makes the disease appear in somebody who's genetically predisposed. So what are those triggers? There is quite a bit of evidence supporting that cancer can often be a trigger of systemic sclerosis and other autoimmune diseases like dermatomyositis, but in a subset of patients. Infection can be another trigger of the disease. And finally, although there's little research looking into the impact of stress on triggering an autoimmune disease, patient after patient comes into my clinic telling me that their systemic sclerosis started after a very stressful life event. So in terms of the pathology that we see in tissues of patients with systemic sclerosis, we know that there is blood vessel damage that is part of the cause of the disease. We also know that there is tissue fibrosis or scar tissue that's laid down in the skin and other internal organs. And finally, we know that systemic sclerosis is an autoimmune disease where your body is actually attacking itself. This is a cartoon that is adapted from a figure created by Laura Hummers from Johns Hopkins University. And basically, I just wanted to highlight that there is some trigger that causes blood vessel damage that then leads to self-sustaining loops where there's altered neural effects causing issues like Raynaud's phenomenon. There's continued damage of the blood vessels and altered repair of the blood vessels. And this leads to a very increased immune response and laying down of scar tissue or fibrosis. So just to touch a little bit more upon data supporting that systemic sclerosis is an autoimmune disease. So if we biopsy tissues of patients with systemic sclerosis, there is clearly the presence of immune cells, and in particular in patients who have early disease. In addition, patients with scleroderma often have other concurrent autoimmune diseases, such as thyroid disease, or they have overlap features with other connective tissue diseases like lupus or rheumatoid arthritis. Autoantibodies are present in the bloodstream of the vast majority of patients with systemic sclerosis. Up to 95% of patients will have these antibodies in their bloodstream that we think are actually causing a problem and attacking the body. There are specific clinical phenotypes that are associated with each antibody, and a phenotype is what the disease looks like. And we'll discuss some of these different phenotypes associated with the antibodies a little bit later in the talk. Finally, therapies targeting the immune system have really shown benefit in the treatment of systemic sclerosis, particularly for interstitial lung disease. And these include medications that you're probably all aware of, like Cellcept or mycophenolate mofetil, and a newer drug that's been approved for scleroderma lung disease called tocilizumab or Actemra. I just wanted to review a little bit about the epidemiology of systemic sclerosis. First of all, it's an incredibly rare disease. Only 1 in 10,000 people worldwide are affected with systemic sclerosis. Females are much more affected than males by at least 5-fold. And the peak age of onset is in the adult years between the 30s and 60s, but both children and older adults can also have new onset systemic sclerosis. African Americans and Asian Americans have more severe disease and often will have an earlier age of onset. And finally, it's a multi-system disease, so multiple different organs can be involved, including scarring of the skin, the blood vessels, and other internal organs. So this slide summarizes some of the internal organ involvement and cutaneous involvement that can be seen in patients with systemic sclerosis. Shown in the top here are pictures of the digital vasculopathy that's related to the blood vessel damage that I talked about earlier, where the blood vessels are really scarred down, leading to poor blood flow to the fingers. and thus these painful digital sores can develop. In larger vessel involvement, you can get acute ischemic injury and gangrene can develop. And this could even result in autoamputation of the fingers. The GI tract is involved in patients with systemic sclerosis in about 90% of patients. And most commonly, it's manifest as reflux or gastroesophageal reflux or GERD. However, any part of the GI tract can actually be involved in systemic sclerosis and lead to what's called dysmotility or slow movement through the gut. There's other vascular changes that can be seen in the stomach lining of patients with scleroderma, and this is called GAVE or gastric antral vascular ectasias, which are blood vessel abnormalities that can bleed in the stomach. Lung disease is the primary cause of death in patients with systemic sclerosis, in particular lung fibrosis. And you can see all this scarring in the CT scan of a patient with scleroderma. Sometimes there's more subtle changes of inflammation that can also cause significant trouble breathing in patients with scleroderma. Pulmonary hypertension or high blood pressure in the lungs is another major cause of death in patients with systemic sclerosis. And it's related again to these blood vessel abnormalities affecting the lung blood vessels, leading to decreased blood flow to the lungs and backup of the blood against the heart, causing heart failure. So cardiac disease can occur in patients with systemic sclerosis, not just related to pulmonary hypertension, but also related to either scarring or inflammation in the cardiac muscle or the heart muscle itself. Renal disease or scleroderma renal crisis is related to, again, a blood vessel pathology where there is decreased blood flow to the kidneys, leading to high blood pressure and rapidly progressive kidney failure. This photo here shows severe contractures of the hand, which can develop particularly in patients with very bad skin tightening. Patients can also develop calcinosis, which is calcium deposits under the skin, and these can ulcerate and be incredibly painful, particularly at the fingertips, where they're using their fingers quite a bit. And finally, acroosteolysis is a change that can be seen in patients, again, related to poor blood flow to the fingers, where there's actually remodeling of the bones in the fingertips, leading to resorption or shortening of the fingertips. So the last point I want to make about the systemic sclerosis clinical features is that it's a very heterogeneous disease. What does that mean? It can present in multiple different ways in every patient. So there are some clinical subsets where we can kind of group patients together, and they often will be overlapping, which I'll show you in one of the figures later on. You may have heard of the limited cutaneous systemic sclerosis and diffuse cutaneous systemic sclerosis subsets. These are the skin subsets that really help us kind of differentiate how a patient's going to do when they first come to our clinic. So shown in purple on the figures are areas that can be involved with skin tightening or skin fibrosis. So you can see in diffuse patients, which about 35% of our patients have diffuse disease, they can have skin tightening or skin thickening anywhere in their body. Whereas limited patients, which comprise the majority of our population, about 65% of our patients have limited cutaneous disease, their skin tightening is limited to anywhere from the elbows downward to the knees downward and can involve the face. But the whole trunk and the upper arms and upper legs are spared from skin tightening. So just to talk a little bit more about diffuse patients, these patients usually have skin thickening that comes on over weeks to months and comes on around the same time as they start developing problems with Raynaud's phenomenon. Early on, their skin can be really swollen or edematous. They can suffer from a lot of itching. And then this leads rapidly to a progressive fibrotic stage where there's rapidly progressive skin tightening. And it's at this time that patients can develop contractures and painful tendon friction rubs. Patients with diffuse disease tend to have early onset of internal organ involvement and overall have a poor prognosis or poorer survival. Patients with limited cutaneous disease usually have a really long onset of Raynaud's, and this predates any other symptoms that come on. So they can have very limited skin involvement. I showed you the figure where they could have involvement all the way up to their elbows or knees, but it can be so limited as just to present with some puffiness of their fingers. In limited cutaneous patients, they tend to have a lot of vascular disease. So they'll present with these dilated capillaries on their nails. They can have digital ulcers and calcinosis, and they can develop these telangiectasias on their face. So this slide shows the natural history of skin thickening in patients with diffuse versus limited cutaneous disease. So here on the y-axis shows skin thickness, and on the x-axis is disease duration in years. Patients with diffuse cutaneous disease tend to have a rapid progression of their skin thickening in the first 3 to 5 years, and maybe even earlier on than that. And at that time, they're at highest risk for developing joint contractures, GI involvement, lung, heart, and kidney disease. And then their skin actually starts to slow down in terms of the skin tightening. And over the subsequent years, they even tend to soften, and patients often will experience atrophy or thinning of their skin at this point. Patients with limited disease follow a very different course. So in the first 5 years or so, they have kind of slow progression of their skin thickness. And this again continues to slowly progress over time, but maybe stabilizes out several years later. And they don't really develop further skin tightening, but late in disease, they're at risk for other internal organ involvement like pulmonary hypertension or malabsorption in the gastrointestinal tract. This slide summarizes the autoantibody subsets in scleroderma. So you can see this is a very busy slide, but it just emphasizes the fact that there are various multiple autoantibodies that can be present in patients with systemic sclerosis. And these phenotypes, or what the patients look like, overlap depending on which autoantibody they present with. So I just want to highlight the 3 most common antibodies in scleroderma are the RNA polymerase III antibody, which is associated with diffuse skin tightening, high risk for scleroderma renal crisis, and association with cancer. The SCL70 antibody is also more associated with diffuse skin tightening, and these patients often present with interstitial lung disease, digital ulcers, and inflammatory muscle disease. And finally, the centromere antibody is really more associated with limited skin involvement, and these are the patients who typically present with long-standing Raynaud's, not a lot of skin tightening, but then can be at risk for pulmonary hypertension later in disease. So now I'm going to shift gears and just describe to you the different types of research that are going on in systemic sclerosis. Basic science or experimental research, it usually involves animals or cell studies and looking at biochemical and physiological investigations. There are also studies on the properties of drugs used to treat patients with systemic sclerosis that are considered basic science. Translational research is that's aimed at translating results in basic research into results that directly benefit or apply to humans, so otherwise known as bench to bedside research. And this might include looking at biomarkers in the blood or looking at drug effects on human cells or human tissues. Clinical research is research that is performed on human subjects. So there is observational research that includes a description or identification of risk factors or outcomes using registry data. And then there are studies looking at new diagnostic tools or algorithms, such as looking at lung ultrasound, for instance, in managing patients with systemic sclerosis. And then there are research studies that are developing outcome measures for clinical trials. In order to better test medications in clinical trials, we have to have outcome measures that accurately reflect the disease. So getting patient focus groups or patient input on these outcome measures is incredibly important, and also getting the input of international scleroderma experts. And then finally, interventional studies in clinical research are those that include clinical trials of novel drugs or studies of non-drug therapies, such as physical therapy or biofeedback. So unfortunately, we do have a lot of challenges in studying systemic sclerosis and performing research on systemic sclerosis. And part of this is related to the fact that it's such a rare disease. So we need large numbers of patients in order to find any significant patterns. As I mentioned, it's also a very heterogeneous disease. So results of studies might not apply to all patients. Doing research is incredibly expensive, and unfortunately, there aren't a lot of sources of funding, particularly through the government, that can be used for these rare orphan diseases. In addition, a long period of observation is necessary to determine a change in clinical outcomes. So it takes a really long time to actually conduct a study from beginning to end. I went over the natural history of the skin disease in scleroderma, and this is actually a major impediment in being able to find drugs that can actually improve skin tightening, because we're never sure if it's actually just the natural history the patient was going to improve on their own, or because of the drug itself. And that's why it's so important to include a placebo in the clinical trials that we conduct. As I mentioned in the previous slide, outcome measures are incredibly important to accurately reflect the disease status or activity that is used in clinical trials in order to know whether a drug is truly effective or not. And finally, this is actually a good thing. We have good treatments now available for the treatment of skin and lung disease in scleroderma. But this makes it even harder for new drugs on the horizon because there's a high bar for them to be even better than the therapies that we have available. I just wanted to touch upon the new challenges to research that have come upon due to the COVID-19 pandemic. First of all, and this is probably the most major effect of COVID, is that we've had trouble recruiting patients to studies. This is in part because a lot of the clinic visits are now virtual, so we're not able to actually do a physical exam on patients and collect biospecimens that are required for studies. And patients are actually less willing to participate in studies because they are fearful for traveling or fearful of having in-person visits. In addition, there are often frequent missed patient visits, as well as staff might be unavailable due to illness related to COVID. COVID infection can also affect the scleroderma disease course, and therefore the outcomes or the measures that we're using to study drugs or other research outcomes is affected by a COVID infection. And finally, the impact of stress. COVID has caused a great amount of stress on all of us. And as I mentioned earlier, stress can impact scleroderma disease manifestations. So where are we going to go in the future with scleroderma research? First of all, we want to get back on track with getting patient recruitment up for our multi-center registries, such as the CONQUER registry that is sponsored by the Scleroderma Research Foundation. We want to be able to study defined subsets so that we can start really promoting personalized medicine or individualized medicine for each patient. But we need patient input on all aspects of study design and protocol development in our studies. So we really want to promote getting patients involved in all aspects of research. Luckily, we do have a potential outcome measure that is currently being evaluated by the FDA. It's a composite outcome measure, so it's measuring the whole status of how the patient is doing, not just the skin or the lungs, but really getting a measure of what the entire patient is doing and how active the disease is in all organs. And finally, we need to implement more efficient clinical trial strategies, studying multiple promising agents at once so that the most effective drug can more rapidly become approved. And finally, what's most important in the future of scleroderma research is working together. So we all need to work together, patients and their families and friends, the investigators, industry sponsors, regulatory agencies, and agencies and foundations such as the Scleroderma Research Foundation and their supporters. So I want to thank you all for your attention. This is my group of investigators and students and coordinators. We all work together as a team at the Stanford Scleroderma Center. And we wouldn't be able to conduct our clinical care and research if it weren't for the Scleroderma Research Foundation. So at this point, I'd be happy to take any questions.
Thank you, Lori. That was a wonderful presentation. And hello to all of you watching. My name is Eric Cao. I'm a physician at the Keck School of Medicine of the University of Southern California, and also a member of the board of directors for the Scleroderma Research Foundation. I'm honored to join you today to moderate the Q&A session for Dr. Chung's presentation. There were a lot of questions submitted. We won't have time for all of them, so I'll try to get a few in that seem to be most frequently asked. So if you're ready, Lori, we'll start. Sure. The first question is, what might a patient with diffuse scleroderma want to be on the lookout for?
So every patient who comes in with early diffuse disease, we recommend that they monitor their blood pressure. And that's to look out for that complication I talked about, scleroderma renal crisis. So this is something that patients can easily do, is check their blood pressure every day at home at the same time when they're relaxed every day. And we ask them to contact us if they notice that their blood pressure is like 20 millimeters of mercury above normal, either on the top number or the bottom number. We also would recommend looking out for early signs of heart or lung involvement. So if they have chest pain, palpitations, shortness of breath, or just even feeling fatigued or feeling muscle weakness, that they should let us know.
Great. A similar question is that what would a patient with limited scleroderma watch for?
So for a patient with limited disease, they're still at risk for lung involvement, actually. And typically, lung fibrosis or interstitial lung disease can come on usually in the first 5 years of disease is when we're most concerned for it being discovered. So again, watching out for shortness of breath or symptoms of fatigue or decreased exercise tolerance, but also issues with limited patients often surround around the vascular disease. So digital ulcers, severe Raynaud's is something that we ask patients to look out for.
Okay. We have a question here. What kinds of complications are most concerning in a patient and that you particularly watch for?
So I think internal organ involvement is clearly the most devastating that can often lead to death. So cardiac disease, lung disease, and kidney disease are the most deadly complications. And, we really look, especially in those early diffuse patients, for those complications.
Great. Another question here is, what is your typical threshold for a new diffuse scleroderma patient to initiate immunosuppressive therapy?
So we are pretty aggressive in terms of starting immunosuppressive therapy in an early diffuse patient. We feel that there's a window of opportunity to really try and halt the progression of the disease. So I would say if there's any evidence of progressive skin tightening, any evidence of interstitial lung disease at all, we would be initiating therapy. Now, a lot of people would say that some patients don't progress in terms of their lung disease, and that is true. So we usually give a window of maybe 3-6 months or so to repeat pulmonary function tests, reassess lung status, and then fairly quickly would initiate therapy if there was any evidence of progressive disease.
Similar question for the patient with limited scleroderma.
So for limited scleroderma, it depends on which aspect you're trying to treat. If they have evidence of lung inflammation, it'll be very similar to patients with diffuse disease, that if we see any progression in their lung function tests, decreasing their vital capacity, et cetera, we would probably initiate therapy fairly quickly if they're developing progressive lung disease. In terms of Raynaud's and digital ulcers, Raynaud's is somewhat subjective when we start therapy. It depends on how many attacks the patient is having per week, how severe the attacks are, and how bothered they are by them. But once a patient does develop digital ulcers, we really want to prevent further tissue damage. So we will initiate vasodilator therapy.
All right. Here's another one. In your practice, what determines the progression from watchful waiting to conservative therapy and or aggressive intervention?
Yeah, so as I mentioned, for early diffuse patients, we tend to be pretty aggressive, and we really want to slow the progression of disease. We typically will start with MMF or mycophenolate mofetil, and if there is progressive skin disease with inflammatory features such as arthritis or interstitial lung disease, we might consider adding tocilizumab. And then for patients who have more scarring in their lungs, nintedanib is another medication that has been recently approved for fibrotic lung disease and scleroderma. There are some patients who also have inflammatory myositis, and we would consider adding IVIG for those patients. And then finally, patients with really recalcitrant skin disease and internal organ involvement, we might consider more powerful medications like rituximab, cyclophosphamide, or even stem cell transplant.
Okay. Well, I think that's where we'll stop today. Thank you so much for sharing your insights with us, Lori. And for all those watching, if we did not get to your question, please know the SRS staff will follow up with you offline following today's forum. Before we go to our next session, there will be a short survey that will pop up on your screen if you'd be willing to share your feedback about Dr. Chung's presentation. Then our next session will begin automatically in just a couple of minutes. Thank you.